Chapter 34, Treatment of Pressure Injuries and Burns. We'll skip past the key terms for now. A pressure injury, which was formerly termed decubitus ulcer, is commonly called a bed sore. A common cause of pressure injuries is lying in a prone position for long periods. Pressure injuries typically occur in patients who are confined to a bed or chair. Patients with sensory or mobility deficits, such as spinal cord injury, stroke, coma, MS, peripheral vascular disease, or diabetes, hospitalized older patients, nursing home residents, and malnourished patients are all at risk. So you can see the different stages. So wow, look at stage 1 versus stage 4. It's a huge difference. Unstageable pressure injury. So you can see now it is black and white versus red. All pressure injuries have a course of injury similar to a burn and are classified in stages according to severity. Pressure injuries can range from a mild pink colorization of the skin, which disappears in a few hours after pressure is relieved on the area, to a deep wound extending to and sometimes through a bone into internal organs. Burns can cause a mild redness of the skin and or blistering, it's first-degree burn, or produce a deep open wound with blackened tissue, and that is a third-degree burn. A pressure injury typically forms from continuous pressure to an area. However, it can also occur from friction caused by rubbing against something such as a bed sheet, cast, or prolonged exposure to cold. The most common places for pressure injuries to form are over bones close to the skin, such as the elbows, heels, hips, sacrum, ankles, shoulders, back, and back of the head. The Norton or Braden scale is a simple assessment tool used to determine a patient's risk for developing a pressure injury. The patient is rated on a scale of 1 to 4 on 5 risk factors: physical condition, mental state, level of activity, mobility, and incontinence. Patients with the lowest score are at the highest risk for pressure injuries. In at-risk patients, aggressive nursing practices such as frequent turning of immobile patients and the application of skin protection to bony body parts can be effective. This 2-hour time frame is generally accepted as a maximum interval that the tissue can tolerate pressure without damage. Pressure injuries and burns are often categorized according to the stages of severity. Stage 1. This stage is characterized by a surface reddening of the skin. The skin is unbroken and the wound is superficial. Examples of stage 1 wounds are light sunburn, a first-degree burn, or a pressure injury. Stage 2, partial thickness skin loss with exposed dermis. This stage is characterized by a blister, either broken or unbroken. A partial layer of the skin is injured and the dermis is exposed. Stage 3, full thickness skin loss. In stage 3, the wound has extended through all layers of the skin. It is the primary site for a serious infection to occur. The depth of tissue damage varies by the part of the body that is affected. Stage 4 wounds extend through the skin and involve underlying muscle, tendons, and bone. The diameter of the wound is not as important as the depth. Surgical removal of the necrotic or decayed tissues is often necessary for wounds of larger diameter. The treatment for a pressure injury involves keeping the area clean and removing necrotic dead tissue, which can form a breeding ground for infection. There are many procedures and products available for this purpose. Topical treatments aid the healing of a partial thickness sore. So box 34.1 lists topical treatments for decubitus ulcers. So some of them you might recognize, like antibiotic ointments. The caplermin is a biologically engineered platelet-derived growth factor. It produces wound repair by increasing the recruitment and proliferation of cells involved in wound healing and formation of granulation tissue. It is indicated for the treatment of diabetic neuropathy ulcers. Collagenase is used to promote debridement, removal of foreign material and dead tissue from a wound in dermal ulcers and severe burns. Commercially available preparations of collagenase like Santal are derived from the bacteria Clostridium histolycutum. Sure. There is evidence that elastin and fibrin are also degraded by collagenase, but to a lesser degree. Papain and urea, an enzymatic debriding ointment, is used to slough off necrotic tissue from pressure injuries, varicose and diabetic ulcers, burns, and miscellaneous postoperative and traumatic wounds. Trypsin, balsam Peru, and castor oil are used in the treatment of pressure injuries, varicose ulcers, sunburns, dehiscent wounds that have come apart, and for debridement of eschar. Trypsin is used to debride necrotic tissue. Balsam Peru increases blood flow to the wound site and may be mildly bactericidal. And castor oil prevents skin cells from breaking down, acts as a protective covering, and helps reduce pain. Antibacterial drugs may be used if the pressure injury is not healing or it continues to ooze after 2 weeks of proper cleansing and bandage changes. Anti-infectives given by mouth or injection are needed for those who have sepsis or infections in the skin or underlying bone. Anti-infectives are also given to prevent diseased heart valves from getting infected or when the injury needs surgical repair. Topical drugs used for the treatment of pressure injuries, which we've already talked about, bacaprolin, which is available as a gel, collagenase, which is available as an ointment. Trypsin, balsam Peru, and castor oil are available as an aerosol or an ointment. The aerosol is Granulix and the ointment is Basilex. Bactrace zinc says that it's not available in the US, but it's like over the counter, so that doesn't make sense to me. Yeah, I'm sure if you went to the pharmacy right now, you'd be able to find that. Gentamicin, which comes in a cream or ointment, also comes in eye drops as well. Just not for this, but just a little side note. We have combination topical antibacterials like cordyceps, and it comes in an ointment, and it has bacitracin, hydrocortisone, neomycin, and polymyxin in it. The next one, it says it's not available in the US as well, but polysporin is, I'm pretty sure, still available. And a bacitracin and polymyxin combination that I don't think is available in the US. It does say it's not, but that one I do believe is not available. The other ones, though, I don't know, unless they change the active ingredients or something. And then we have the antiseptic povidone iodine, which is betadine. This is available as a scrub cleanser, a solution, a spray. And we talked about it in chapter 33. So if you want to return there, you can look at additional dosage forms. Typically, we think of a burn as a thermal injury or lesion caused by contact of the skin with some hot object or fire. In addition, overexposure to UV light, sunburn, or contact with an electric current, corrosive chemical, or radioactive agent can cause injury or death to skin cells. When burns involve large areas of the skin, treatment and the prognosis for recovery depend in large part on the total area involved and severity of the burn. The severity of the burn is determined by the depth and extent, the percentage of body surface area, the BSA of the lesion. Another method is the rule of nines. In this technique, the body is divided into 11 areas of 9%, with the area around the genitals called the perineum, representing the additional 1% of BSA. The rule of nines works well with adults, but does not reflect the differences of BSA in small children. The depth of an injury, burn injury, depends on the tissue layers of the skin that are involved. A first-degree burn, a typical sunburn, causes minor discomfort and some reddening of the skin. First and second-degree burns are called partial thickness burns. Second-degree burns involve the deep epidermal layers and always cause injury to the upper layers of the dermis. In deep second-degree burns, damage to sweat glands, hair follicles, and sebaceous glands can occur, but tissue death is not complete. Third degree or full thickness burns are characterized by destruction of both the epidermis and dermis. Tissue death extends below the follicles and sweat glands. If the burn involves underlying muscles, fascia, or bone, it may be called a fourth degree burn. Sloughing of skin, gangrene, scarring, erysipelas, which is a skin infection caused by staphylococcus, nephritis, which is kidney infection, pneumonia, immune system impairment, intestinal disturbances are all possible complications. The risk for infection and dehydration is greatest when more than 25% of the body surface is burned. Signs of infection are change in color of the burned area or surrounding skin, purplish discolorization, particularly if swelling is also present, change in thickness of the burn, green discharge or pus, and a fever. Signs of dehydration are thirst, lightheadedness or weakness, dizziness, dry skin, urinating less often than usual. Sunburns obviously can be prevented by using sunscreen or sunblock and avoiding excess exposure to UV radiation. Chemical-related skin burns can be prevented by avoiding strong chemicals. Stop, drop, and roll should be the first action if a person is on fire. A rug, blanket, or anything within reach can be used to smother flames. Care must be taken so that the individual does not inhale the smoke. Clothing must be carefully cut away so that the skin is not pulled away. Blisters should not be open because this will increase the chance for infection. All burn patients must receive appropriate tetanus prophylaxis. Treatment involves the administration of antibiotics, analgesics, and fluid replacement. Non-pharmacological management includes monitoring cardiac output, tissue perfusion, urinary output, blood pressure, pulse, body weight, and renal function. Fluid balance is carefully monitored as well as nutritional therapy. So box 34.2 lists management of severe burns. Silver sulfadiazine is the most frequently used topical agent for burns. It is used to prevent and treat infections in second and third degree burns. The drug is bactericidal against gram-positive and gram-negative organisms, but resistance has occasionally been reported. Silver nitrate is a broad spectrum agent. It is bacteriostatic at a concentration of 5%. Povidone iodine acts by destroying microbial protein in DNA. This drug has excellent in vitro antimicrobial activity, but is inactivated by wound exudates. Systemic absorption of iodine results in renal and thyroid dysfunction. So we have some more topical treatment of burns, sulfamylon and sulfidine and thermazine. Now we have the summary of drugs used in the treatment of decubitus ulcers and burns. So we went over all these, but we'll talk about the warning labels. So for the collagenase and the granulix are debriding agents. We are not going to touch the tip of the tube to any surface, including a finger, the wound, or sterile gauze pad. The aerosols are flammable. For topical antibacterials, they should not be used longer than 1 week unless prescribed. Gentamicin, we should have the patient report any dizziness or sensation of ringing or fullness in the ears. For Bactroban, discontinue if rash, itching, or irritation occurs. For topical use only. Silver sulfadiazine, the Silvadene cream, for external use only. And you can see that it says apply with a sterile gloved hand. Sulfamylin, discontinue and report immediately if rash, blisters, or swelling appear while using the cream. This one also says that you should use a sterile gloved hand. Silver nitrate, apply a cotton applicator, and you should discontinue that if redness occurs. And then for betadine, do not swallow. Remember, systemic consumption can lead to renal and thyroid dysfunction, and it should be used only externally, and we should avoid contact with our eyes.